Okay, so welcome to everyone who is watching this session right now, and welcome to each and every member of the ICU channel who have requested this session for so long. I have received a lot of requests on the ICU channel, on my personal email, on Telegram, on WhatsApp for this session. And I'm very fortunate that finally this session is happening. And today, I don't know how to start, but without wasting any time, I would like to welcome Dr. P.K. Jain, the my mentor, my teacher, my godfather. You can name anything for me. My career started in critical care when I saw him at the first time, and I still remember the date. It's 9 July 2011. So, namaste, sir. Very nice to have you here. And before I start this session, a little bit about Dr. P.K. Jain, though everybody knows it. But Dr. P.K. Jain is one of the pioneers who started critical care in India. He started with, in 1993, founded Indian Society of Critical Care Medicine, which you know as ISCCM. Then, over the period of years in that decade, he started IDCCM, Indian Diploma in Critical Care Medicine. Then he also started Indian Journal of Critical Care Medicine. He was the chief editor for that matter. And then in 2003, I think, if I'm not wrong, he founded Critical Care Education Foundation. He's the founder, chairman, president, anything you can say of CCF, which we know. And then he brought PCCCM and FCCCM courses. So we'll discuss about that. But once again, eh, many thanks to you, sir, for sparing time and joining this and recording this session for our audience on so many requests. Once again, namaste, sir.
Thank you, Ankur, and congratulations on achieving this wonderful landmark of 100,000 viewers and members on your ICU channel. That's a great achievement in such a short time. It's all because of your hard efforts. We're very impressed.
Thank you, sir. So, uh, sir, before starting today's session, I would like a small question that when in 1993 there was nothing, not so much a buzz about critical care medicine at that era, I think. So how you started this critical care, how did this idea came into your mind that you should start a society for critical care medicine, and this is something which is the need of the hour at that time? A few just share moments with us.
There was really nothing organized critical care. Pockets of hospitals were doing something in critical care, but there was no teaching or training. And I thought it was very important. The first topic that I heard, I did my MD pulmonary medicine, non-tuberculous pulmonary medicine, and I finished the theory exam. My practical exam was remaining, and I heard this wonderful lecture on ARDS, and ARDS fascinated me. And so I decided that instead of my pulmonary medicine, I'm going to move on to critical care. So I went to a great intensivist at that time and learned with him. But when I decided to make it a career, the advice I got, and you'll be surprised, is that if you become an intensivist, how will you feed your family? There is no demand for intensivist. You've done your pulmonary medicine, you do bronchoscopies and you do so many things. That's what you should practice. Why do you want to go into critical care? But I thought the future was critical care, and we needed to do it in an organized way. And being a Bombayite from Bombay, I didn't want Jumri Talaiya to start a critical care society and we become the Mumbai branch of Jumri Talaiya. So you understand what I'm trying to say, that I thought that Bombay should have the honor of being the first place where it originated. And so we started with 5 people. Well, how we became 10, because 10 was required to form a society, was we added a spouse's name. It was, I thought at the peak of critical care will be 100 people, but we never thought that the demand was so much that, like today, there are 20, 30,000 people practicing critical care. It's wonderful.
This is something very interesting, sir. Means when I think of it, when I reflect on it, it was such a long vision at that time in 1993. Nobody was talking about critical care medicine, and then you started with this, and now see, it is one of the most demanding and booming branch, not only in our country but across the globe. Because no hospital can imagine their unit without an intensive care unit or emergency department. Okay, sir. So let's come to today's session. Means today's topic, Sherlock Holmes approach in critical care medicine. So when I first heard this term, for me it was Sherlock Holmes was a very fascinating character in detective. There was novels and movies on him. This character, fictional character, and the quality of this character was that he was a good observer. The power of observation of this detective was tremendous, means very USP of that character. So Sherlock Holmes in critical care, what does this mean? Can you just tell us what this Sherlock Holmes approach means actually?
Yeah, it's sad that I see a lot of people practicing critical care today without really using their head. It's do a lot of investigations, okay, and something will come abnormal and chase it from there. Uh, Critical care isn't about procedures, but everyone thinks I can put in a central line, I can intubate, I can ventilate, and therefore I am an intensivist and I don't need any further training. I can read an ABG, however preliminary their knowledge is, but uh, I thought that we are losing an essential skill that our forefathers had, the power of observation and the power of deduction. And for the last 20 years, me and many of my students who have now become teachers have been spreading this, and it has a lot of advantages. Um, uh, the advantages, you save cost. With simple investigations, you can make a profound diagnosis or narrow down the differential diagnosis. It's time saving, and therefore you don't spend days coming to a diagnosis. Within seconds, literally less than a minute, you have a fair idea of what you're dealing with. And therefore these advantages are very important. It basically consists of observation. Okay, we have, how often do you see intensivist examining the patient rather than looking at the x-ray, CT scan, ABG, and the biochemistry, and really not touching and looking at the patient? So the power of observation, power of deduction. Today majority of people feel that, oh, hypokalemia, just replace potassium. Hyperkalemia not coming down, dialyze the patient. So it's like a one liner, if this then this. There's a lot of diagnosis that you can establish to think, why did it happen? And no one thinks about the behavior in the body. So like if sodium goes down, so should potassium and so should chloride, but no one looks at this. What if one comes down and the other does not? Why did that happen? If sodium comes down but the chloride goes up, or the sodium goes down, the potassium goes up, these have tremendous diagnostic values. They're called patterns, which we need to learn. And we coined the word Sherlock Holmes basically to grab attention of people,
Okay.
to make them realize that if they learn it, then they can make bedside critical care very interesting.
Okay. So, so what I can understand that Sherlock Holmes means observing things what is happening with the patient right now clinically. Did you getting some ideas in the mind and seeing the pattern, picking up the patterns, the investigations, the minimal bare minimum investigations, and then coming to a conclusion and at least narrowing down the things and which can save time and can be beneficial to the patient with minimum cost. That's what I can hear, sir. Though we have listened this Sherlock Holmes approach many times from you, but the audience which is who are listening right now, can we show them some glimpse of, or with few examples, can we show them certain glimpse of this Sherlock Holmes approach so that they can have an idea what we are talking about? how this technique is so powerful that everybody who is working in the intensive care should know this. Can we
Okay.
have some examples?
Sure, we'll do that. But with your permission, Ankur, can I just first say that why it's important for an intensivist to adopt the Sherlock Holmes approach?
Yes, sir.
Okay.
Yes, sir.
You see, who is an intensivist? Okay. And I already said that intensivist is here and
Hmm.
not in the hands. It's not in the technique, but the thinking, analyzing part of it. That's very important. Now, the best way I can say is that intensivist is like the black cat or commando that you have. If there's a hostage situation in a plane, right? You don't call your inspector or your commissioner of police. You call the black cats because they've got special training. And what is this special training that you've given them? Well, the scenario is there's a hostage situation in a plane, but you don't have information. You call the black cat, they may be sleeping, they may be eating, so you don't give them enough time to prepare. You expect them to go in, but you don't tell them how many terrorists are there, what weapons they have, where in the plane they're located. But you want to them the black cats to go in and capture all the terrorists and not harm any passengers. And does this ring a bell of how intensive care is similar to that? Patient comes in collapse, he doesn't carry his medical files with him, he comes in, the person bringing him often doesn't know enough, and he's sinking in front of you. So is this an asthmatic who's gone very bad? Is this a myocardial infarction going bad? Is this a cerebral hemorrhage? No, you don't have the time because he's collapsing in front of you. You've got to pick up clues and make the best guess. And if you make the best guess correctly more often, you will be successful as an intensivist. And if you don't, then your career is not going to pick up. So that's why it's important to understand, uh, to adopt this Sherlock Holmes approach. I can show you with a few slides. So let me just,
Okay. So when you are ready, let me know.
okay. So I'm ready.
Okay, sir. Yes, sir. We can have it.
If you can see this, these are real cases. First of all, these are true cases,
Hmm.
and we've built over the last 2 decades a
Hmm.
big library of scenarios which we use for teaching. Like this boy, this is a boy that we saw in Cochin when we were traveling there and lecturing,
Hmm.
and the head of intensive care said, I've heard you talk a lot, but can you come to my ICU and show it in practice? So the first case was this boy who was there lying in bed, young boy. He was not connected to the ventilator. He just had a bed sheet on. We said, remove the bed sheet so we can observe him. What did we observe was that in his groin, he had a dialysis catheter. And when you see a dialysis catheter, you say, oh, maybe he's got renal failure. So we looked at the other side and we found that there was a lot of urine in the urine bag. Now, who would dialyze a person who's producing a lot of urine? So obviously, our first assumption that this is a dialysis catheter was wrong. What could else could it have been? The second most common thing is plasmapheresis. So this is the plasmapheresis catheter, and which is the commonest scenario in which you do plasmapheresis is GB syndrome or infective polyneuritis. So we said that this patient has GB syndrome. The whole process of deducting that he has GB syndrome and not status asthma recovering or poisoning recovering or GI bleed recovering took us 20 seconds. Do you understand? What did we do here? Observation and deduction. We observed a dialysis catheter. We deducted that maybe there's renal failure. We saw a lot of urine. We corrected our deduction that it is not a dialysis catheter, it's plasmapheresis, and then narrowed down. So this is the Sherlock Holmes approach. You observe something, you correlate them, and then you deduce the most likely reason.
Fascinating, sir. Those who are watching, I think for them, I think they will be very fascinated by this thing. In 20, 30 seconds, the approach changes. How you are looking to the patient, how your deduction. So, deduction, I think, is very, very important. We may be good at observation, if at all we are, but deduction is something which we need to come out. And in the technology world, I think this deduction part is getting missed in most of the times. So,
Very true.
can,
Can I
can
show you another case
yes,
just to
yes,
highlight this again?
yes, sir. Yes, sir. Huh.
Now, if you look at this, I hope you can see it.
Yes, sir.
Is if you were to ask why was this boy admitted, and this is a patient that we saw and managed in Surat. We were called in as an emergency. If you look at this, and the way we train our candidates is we show them the picture, we ask them to say things, and then we ask them what was the reason, and then we correct them. And the answers I've had in the past is, oh, this is a GI bleed. Oh, this is a poisoning case with maybe organophosphorus. Maybe this is an operated abdominal case. Maybe this is a fracture somewhere. It's just without any reason. They're just making guesses. But what we see, the three golden rules of critical care: assume nothing, trust no one, and the third one is if you don't know what to do, at least start oxygen. But very important, assume nothing, trust no one. So you cannot guess when someone's life is at stake. Now, if you look here, you see that the
Urine
urinary
is green.
catheter
Urine
has
is
green colored urine, the
green color.
bag has green colored urine, and the commonest really reason why you have green colored urine is methylene blue being given. And if you look at the arm, you can see some stains of methylene blue in the arm below.
Yeah, yeah.
Uh,
Oh,
so if methylene blue is being given, well, methylene blue is given for various reasons now, but one of the important reason is methemoglobinemia.
yes,
And
sir.
so you saw this and you say, okay, let me confirm methemoglobinemia because there should be a disparity between the saturation and the blood gas PO2. So what we did was we looked at the monitor, and the monitor showed that the monitor showed a saturation. If you can see it, I think it's 84,
Yes, sir.
uh,
84. Hmm.
and but the PO2 is 173. PO2 of 173 should give you a 99 to 100% saturation. When you have this discrepancy, where your PO2 is good, but your saturation is not, that confirms methemoglobinemia. And if it was the reverse, you would have thought of carboxyhemoglobinemia. So this confirmed methemoglobinemia. But it doesn't end there. See, again with the power of observation, so we have already deducted that by power of observation deduction that this is some poisoning. But can I actually say which poison? Was this TIC20? Was this diazepam? Was whatever was it? Uh, Look at the IV fluid, and you see this typical pink color, which is of B12. Okay, and B12 is a specific antidote for cyanide poisoning. So
Amazing.
this was a case of cyanide poisoning. Power of observation deduction. We didn't touch the patient. We've just diagnosed this based on a photograph taken there. And this was a patient who got copper and zinc cyanide poisoning because he worked in a cloth dye factory, and the factory caught fire. They put water and it got absorbed through the skin. So we had about 18, 19 people who were there, all with cyanide poisoning, and we didn't lose a single one. So
Amazing, sir.
that's about
So,
it.
it seems like we are seeing a movie itself. That I thought it will get stopped at this methemoglobin discrepancy, the PO2 and SPO2. Never thought that we can reach to the cause also. In fact, in the first glance, I could not see that pink bottle which is there. Our focus was only on the patient per se. And in the slide there at the browser, you have written no history, no touching patient. So this means this was.
That's what we used to have our students practice this,
Uh,
because if you give a history and and if they touch the patient, they really don't observe.
okay.
So we tell them, look, it's first very difficult to convince people that by observation you can make deductions. They think it's not possible, or it's just in one or two cases. And I can tell you, 20 years, every day is a challenge, every day is exciting. And one thing that all my residents say is that every morning when we get up, we are so much in a hurry to come to the ICU because it's exciting. And that's what we want. We want the ICU to be exciting for the residents, not, oh, I have to go to the ICU. It's something I have to do. It's drudgery. No, it should be fun. It should be like a roller coaster. You should enjoy it.
So I really miss working with you for some reasons, but it was I had spent some 3 4 months with you, and it was both fun as well as a stress on my head that if I'm missing something, I'm not observing. I would I cannot explain that experience, because at the bedside, whenever you are at the bedside, you and when you are standing by, it's always on the thought process. If we are missing something, if we are missing something, but over a period of time, you have trained that focus on the patient, you will get something out of it. Sir, can we have some more because
Yeah,
it's
see, this
becoming more
power of
more interesting.
observation is not just at the bedside of seeing the patient, but it can apply to anything. It can apply to the blood gas report, it can apply to the biochemistry report, to the hematology report, it can apply to the X rays, ECGs, to every aspect of critical care. The power of observation and deduction. So, let me start with some simple cases that, again, every case is a true case.
Hmm.
This is a patient I saw in Delhi when I was inspecting the ICU and for the purpose of recognition, and a patient happened to be there. A 48-year-old female is admitted with sudden onset of severe pain in the back, compatible with a spinal cord compression. And these are the values, and we say, okay, the spinal cord compression, we'll get an MRI done, we'll see what is happening, etc. There, and that was it. And in fact, you'll be surprised that the chloride wasn't done at that time. And so
I
when I asked you,
remember. I interrupt you, sir. Exactly. To all the audience who are listening, that when sir came for the first time for inspection of the our institute, for recognition of the institute for this fellowship. So I was a very one of the junior most resident, and I was very scared that somebody is coming for inspection. I was on the duty, and I was praying that nobody should ask me anything. Nobody should ask me anything. But it was destined that out of all the team members, sir picked me. Can you come here? And then he asked me in the ABG, can you come? What's wrong in the ABG? I was scared. I told sodium, potassium, other. Sir asked me specifically, what is happening with the chloride? Can you tell me about it? And I have no idea that chloride is so important at that stage. I think this example will make people understand why this chloride is so important.
I was shocked at the response. Not only was the chloride not done, but the
Uh,
intensivist who was qualified in critical
uh,
care,
uh,
he had done a fellowship or whatever, something from another organization. He said, "Sir, I have done this exam, very senior, and chloride has no role in critical care medicine." But the medical director was accompanying me on the round because I was inspecting it, and he says, if Dr. Jain is saying, at least get it done. So
mm,
it came as 110, and it took me 10 seconds to make a diagnosis of this patient. So let me share it with you. It's question of pattern, and you see that sodium has gone down, but the chloride has actually gone up. It had no business to do that. If sodium goes down, the chloride also goes down.
mm.
Okay, and when you see this pattern, you should look at the Sherlock Holmes training, and this is Sherlock Holmes rule number 26. Sodium and chloride should go hand in hand. If not, there is hidden trouble.
Oh,
So if you just look at the sodium and don't look at the chloride behavior, you're not seeing the total picture. You're just seeing through a tunnel vision. Now, so what you should do when they don't go hand in hand is you should do the anion gap. So in this case, we did the anion gap, which is sodium minus chloride plus bicarbonate, and it came as -4.
oh,
A negative anion gap, unless proved otherwise, a negative anion gap is multiple myeloma, especially when you have a history of back pain and cord compression. The other very important differential to consider is always lithium toxicity, but nothing in the history pointed towards that. So you see, 10-15 seconds, we made a diagnosis of multiple myeloma in this patient just looking at the electrolytes. That is the Sherlock Holmes approach. And if you practice it, what will happen is you will enjoy being an intensivist, you'll enjoy coming to the ICU, your residents will enjoy working there, you will impress your colleagues. And so it's something that's very, very important to learn. Show you another report because it's something that we pick up every day. A 32-year-old male presented with vomiting and loose motions for 3 days, and BP was 80 by 30. There was no history of paramedications. And you look at this and you say, what's great about it? Someone who's a young person has got gastroenteritis, his BP falls because he's hypovolemic. So the treatment is give him fluids. But again, if you look at it, you must pick up any abnormal pattern. And here the abnormal pattern is again that sodium is going down, but potassium is going up. If it was dehydration due to gastroenteritis, the potassium should have been low. And therefore, don't ignore it. Don't say it's a lab error. Okay, try to find a cause. And when we see this pattern of a low sodium, high potassium, again, Sherlock Holmes, that was 26. This is rule number 27. Sodium and potassium should go in hand in hand. If not, there are three. And that's the husband coming in through the door. So that's the third person there. So if sodium and potassium don't go hand in hand, there are three. The three means there are three diseases and three drugs you should think about. And the three diseases are DKA, renal failure, adrenal insufficiency. And three drugs are potassium sparing diuretics, ACE inhibitors, and indomethacin. Now, the history doesn't tell us that there is any prior medication, so we can ignore points 4, 5, and 6. What about DKA? Could this patient have DKA? But the blood sugar is 65. If at all, it's
Oh,
on the lower side.
low
So
aside.
it's not there. Renal failure, well, the creatinine is mildly raised, and this is in milligram per deciliter and not millimoles. But you can look at the upper normal value and say that it is slightly raised. Though the creatinine is raised, it's not enough to give you a potassium of 5.8. So you're left with adrenal insufficiency. Could this be adrenal insufficiency? Definitely. The glucose is slightly low, there's a mild metabolic acidosis, and the clinical presentation. This was an asthmatic who was on steroids. He got gastroenteritis, they stopped the steroids, obviously, stopped the oral tablets in every form, and then he became hypotensive because he went into adrenal insufficiency. All we had to do was give him 100 milligram of hydrocortisone 2 3 times a day. BP came up, we gave him fluids, and that was the end of it. So this was adrenal insufficiency.
Could not
If
have
we
picked.
didn't give him fluids, he probably wouldn't have responded as well, or it would have been a very temporary response.
Obviously, by the history, I think if this history is given and this potassium is high, most of the time we will have thought that this is because of the hypovolemic shock and because of the renal failure.
Or hemolyze sample.
Hemolyze sample. Obviously, first thing we do that. Even if then that is excluded, then in a normal scenario we would have thought that it is hypovolemic shock, impending renal failure, and potassium is increasing because of that. But I think, sir, um, sodium low means in dehydration. I think it should go up. It should be hypernatremia, I think, and this.
It can be either way, Ankur. You know that very well.
Uh,
That it sometimes it depends on whether the sodium loss is more than the water or the water loss is more than the sodium.
hmm,
So patients differ. Usually the sodium does fall,
hmm,
but if the water loss is more disproportionate for some reason,
hmm.
then it will be high.
But this, without this pattern recognition, I think reaching at least to adrenal insufficiency would be not an easy task because it requires a lot of 2 3 days not picking up, even if we picked up. But something, this is very amazing to the audience, those who are listening. This is what we are trying to say, that Sherlock Holmes approach means the power of deduction by seeing the patterns what is happening. Sir, do you have something more in your
Yeah,
bag today?
so I showed you clinical bedside. I
Uh,
showed you a little bit of biochemistry. So this was adrenal insufficiency.
One or two
Let me tell
examples,
you
sir.
this interesting patient we saw in
Hmm,
Mangalore.
hmm,
I was giving a talk on hypokalemia, and there was a pediatrician sitting in the audience. Uh, and she told me about a patient, very intelligent pediatrician. She says, "Sir, I have a 12-year-old boy with chronic unexplained hypertension, that not very hypertensive, slightly on the higher side, but whose potassium is persistently low and there's metabolic alkalosis." She tried in her own way to work up the case and said the urinary potassium levels were very high, the urea creatinine was normal. She did the renin aldosterone levels, they both were raised. And she said, I thought about renal artery stenosis in this child. And that was a very good thought, very good differential diagnosis. But she said, I did imaging and there was no renal artery stenosis, and I don't know what to do. So, just with this history, without seeing the patient, without saying anything. And it took again 5 seconds. I said, this child that you're treating has coarctation of aorta. And they said, well, you've not seen the patient, and I've given you hardly any data. And I said, look, you've given me enough data. There is no differential diagnosis. There's only one. Your child has got coarctation of aorta. I'm going back to Bombay, but after 15 days, because it was an outpatient case, I said, when you see the patient or you call him and you work him up, give me a call. And when I came back to Bombay in 5 days, I got a phone call, sir, there's coarctation of aorta. Uh,
How is with
it's
this
just
data,
the power
sir?
of deduction.
How with this data? How which
Okay,
is
let me tell you, it's just you have got to understand the behavior of electrolytes and acid base in the body. So I'll tell you how we got to coarctation of aorta. Whenever you have hypokalemia
Hmm.
and you have high urinary potassium, that means the kidney is the culprit. There's a potassium losing
Correct,
nephropathy.
correct.
Otherwise, with hypokalemia, the kidney should conserve potassium, right? So we came to is the potassium losing
Renal
nephropathy.
con.
That means the kidney is the cause.
Okay.
Then you need to look at whether there's metabolic alkalosis or metabolic acidosis. Like in renal tubular acidosis, you'll have the same picture of hypokalemia with metabolic acidosis. Here there was metabolic alkalosis and the child was hypertensive. The sodium, the urea creatinine ratio was normal, which indicated that he was not hypovolemic. So it was not someone who's on like Bartter syndrome on diuretics.
Hmm.
Okay, so we came to the point, which this lady also came to, the dog pediatrician, that it's a mineralocorticoid excess, and she did the renin aldosterone level, and because both were high, this was secondary hyperaldosteronism.
Okay.
Basically, there are two important causes: renal artery stenosis and coarctation of aorta.
Hmm.
And she did the half the job for me because she already ruled out renal artery stenosis. So what was left?
Coarctation.
Coordination of attack. Once it's like a magic trick. Once you tell how you did it, it's not impressive as much.
Hmm.
But like a magician, when you show it for the first time, tremendous impact. How can you look at just potassium and metabolic alkalosis and say coarctation of aorta? So
Yeah,
that,
that too, just somebody who has worked up on that giving you the first slide, and suddenly you come up with the diagnosis. It's amazing. You tell us in the first session, first few minutes, that at times it helps to impress others also, though that's not the first
yes.
task, but it helps to it does as a byproduct, I think.
Yes, we are human beings, and it. I always like it. Even now, when my consultant colleagues get impressed,
Hmm.
okay, and I also like it when my residents get impressed, and uh, you know, jokingly and with no disrespect, the female residents get very impressed, and you like it even more. Uh, Overall, I think by adopting this interesting approach,
Hmm.
you reduce the burnout. ICU is a horrible place because of the stress that is there, the large volume of work that needs to be done, the chaos that is there, and intensivists suffer from a burnout. But if you make your daily work in the ICU interesting, there it reduces the burnout. And many of my residents who have now become consultants are carrying forward this legacy, and they're teaching their residents the Sherlock Holmes approach. You are teaching a lot of people the Sherlock Holmes approach, so it makes working in the ICU a fun place.
Amazing, sir. Though I have listened to this Sherlock Holmes approach right from the day one, still listening to these cases again makes me so fascinating that it's again, whenever you listen it, it fills the eyes with joys that this is something which is you can't miss it. Sir, do you have something in your bag more for us, or one or two more? Yeah, just at least
No,
one.
I just brought in a few. There are limitless amount of information that's actually there.
Okay. Okay.
So
Not an issue, sir. But these 4 5 examples have shown which what was the purpose actually, that to all the audience, those who are listening, this was the purpose to show that what is Sherlock Holmes approach is all about, how this can be applied in your ICUs. Now, having listened about this, having knowing about it, how it can be applied in your intensive care unit. So my next question is, how can we learn this? Means those who are watching, and even me again, I know some part of it, still learning. But where can we, means where can we learn about this? How can we learn at this stage? Some are working, some are doing, pursuing their courses, some are working in the ICU. So how can we learn about this Sherlock Holmes approach?
Yeah, I think it's not very difficult if you're interested in learning. There, uh, basically, there are no books that you can learn from. There, it's all of medicine, but you need to work with someone who is. It's like, you have to be Watson and you have to work with Sherlock Holmes to see it. But it's not practical for everyone to leave their work and come for a year, 2 year. There are 4-day courses that we have done, intense course for doctors, where we explain this science of Sherlock Holmes, how to correlate things, etc. And it gives them a very good foundation. I would say that they learn 30-40% of Sherlock Holmes approach in 4 days. It's a very intense morning to evening learning. But apart from just electrolytes, ABGs, we tell them about ECGs, we tell them about every aspect that is there. And then they go back in their own environment and then they practice it. And we can put them in touch with one of a trained Sherlock Holmes trainer near them, so that today, either on WhatsApp or email or just telephone or video call, you can get in touch with someone. Most of the time, I'm also available to everyone. I'm very passionate about it, so you can call me up and we can discuss the scenario. Maybe I learned something new. Maybe we'll have something to share next time because it's interesting. All my cases, by and large, have been actual cases shared with me, or where I've been invited to manage the case. So that's how they can learn there. And but you cannot learn from books, and you cannot really learn online. You have got to get the feel. You've got to learn to make mistakes. The biggest mistake people make is just listen, and by listening you say, oh yeah, I would have picked up the green urine there, I would have also thought. But my 20 years of practice in teaching says that 99.9% of the time people don't see it. It's there in front of you, people don't see it because we have not developed our power of
Training,
observation, of
training,
closely observing. So you
training.
need to work, you need to be the first to actually interpret, and then let your mentor correct you.
This
So
is very,
that's
very
how it
important.
really goes on.
Train your mind, train your, means train your eyes and train your brain to pick up those things. So again, coming back to these questions, you said that, sir, there are, you have done 4-day workshops for this in the past. But those who want to do certain courses, do CCA provide certain courses? Because I know they provide. So can
Yeah.
you just share a little
That's a
bit
very
about?
good point.
Hmm,
You can't become Sherlock Holmes in 4 days.
hmm,
Trust me, Watson spent decades
hmm,
and didn't become Sherlock Holmes equivalent. So, but that's just an orientation sort of a thing that is there. It takes about minimum 2 years to be fairly good in bedside critical care. And because a critical care person,
hmm,
whether he's from a medicine background or anesthesia background or pulmonary medicine background, they're all inadequate from intensive care point of view. The anesthetist is very good with procedures, but he doesn't understand diseases and treatment as well. So he's got to concentrate on that. And remember, and you know very well that when we train people and we evaluate them, we evaluate them in all aspects. So critical care neurology, cardiology, critical care gastroenterology, critical care endocrinology. You don't know what you're going to get next patient, and therefore you have to be able to be good, fairly good in all aspects. You should be able to not just rely on the neurosurgeon. You should have a fair idea so you can discuss with him and tell him where you disagree with something, or disagree with the cardiologist or the endocrinologist or whatever. You need to be fairly good, and that cannot happen overnight. It's MD medicine takes 2 3 years. Same way, you need to spend some amount of time. But Indians are very good learners if they set their mind to it. And therefore, we found that even in 2 years of training, they've got all the tools they need to continue to progress. Those who have done medicine, again, they need to learn techniques. They need to learn how about ventilation and other things, central line care procedures. And a pulmonary person, even with his MD, he needs to know cardiology, neurology, gastroenterology, a lot of other things. All that he's good with is blood gases and ventilation, but other things. So for everyone, there needs to be a formal training, and that is through the Critical Care Education Foundation, which has the College of Critical Care under it. Now, the college started in 2002 or 2003, almost a decade before ISCCM started it. And we have been training people. The first year is for about 70% of the knowledge that they should have. The That's called the primary, or the PCCCM. Once they clear that, and they're good with data sets, they're good with Sherlock Holmes approach, they're good with ECGs, X-rays, equipment, etc. Then the second part, which is the final, the exit exam, is the FCCCM, where they've got to learn more sophisticated. They need to know how to do echo. They need to know how to interpret it. They need to understand medical statistics, how to interpret and read and critically appraise a research paper published in the journal. They've got to know so many other things, hemodynamics, antibiotic selection in more detail. And every aspect of it is evaluated in the exam. The good thing is, you'll be surprised, there's no other exam where all the examiners give the exam one day before. The same exam which candidates are going to give. Examiners give this exam, and that we feel as is being very important, because unlike other exams, and I've been an examiner in many, the examiner himself may not know the answer, but he'll ask the question to candidates. Or he may have read something in the past 2 3 days, and he won't expect the candidate to know something molecular about ARDS. That's not a fair question. Okay, so there is no validation of the questions done. We feel that if even one examiner cannot answer a question, it's not fair to ask the candidate. And unlike other exams where there are 4 or 5 examiners evaluating you, so which means if there are 4 examiners, each examiner has the power of 25% to alter your marks. So if 2 examiners don't like you, you will fail. And even for that matter, one examiner doesn't like you, there are good chances, for whatever whimsical reason, you can fail. But in this exam conducted by the College of Critical Care under CCEF, you face around 20 examiners. So each examiner just has the power of 5. So even if he hates you, maybe from 80 you'll come to 75, or from 70 you'll come to 65. It's very unlikely, unless you're absolutely borderline, passing being 50 and you're 53, then maybe he can make a difference. But you're borderline anyways. So there are lots of beautiful things about this exam, which make it very unique. And that is why many of the hospitals abroad, when candidates apply for fellowship, whether it's in Canada or UK, they prefer to take our FCCCM candidates, because the previous candidates have been very impressive. Even in the Middle East, the I keep getting feedback and say, though the intensivist head of department is America trained, but your students are very good. So that's the thing.
So nice, and whenever I listen to these stories, na sir, it becomes it's a the goosebumps comes, because I have seen candidates passing through this exam and then sharing their stories. I still, so when you were speaking that, all those moments were coming in front of my eyes, how they were sharing their stories in UAE, UK, Canada. So I have personally witnessed few of them. So it's something which is very emotional for them and for us also when we listen these stories. So again, just for the audience, those who are listening, the College of Critical Care under CCF organizes 2 exams. One is 1 year PCCCM, primary CCCM, and other is the fellowship FCCCM. You can go in the on collegeofcriticalcare.com to get the more details. But sir, few details we want to clarify from you yourself, because at times there are a lot of questions regarding this on my channel. Uh, One of the things is regarding two things particularly they ask. One is the eligibility. Who all can apply for this exam, whether it should be MBBS, MD, MS, means like that. And secondly, the other, which is very very important, whether they need to means leave their job and come to a training institute, or from they can apply only from India or from across the globe. So these two questions, the eligibility part and from where they can do this.
Okay. Now, there was a lot of pressure on us 20 years back when we were starting this, that it's a super specialty. It's not even a specialty, it's a super specialty, so restricted to just MD candidates. But India is a very large country, and according to our research and estimate, there are upward of 50,000 ICUs in India, and we need about 3 to 4 lakh intensivists well trained at any time. Okay. Now, 2 3 organizations which are training people are maybe producing say 100 intensivists a year, and in 100 years that will be 10,000, right? And in 100 years all will die. We need 4 lakhs. We're just not going to cross it. And to restrict it to MD, you see, a person who's done MBBS, MD, who's taken loans from his father, and he's in a hurry to start earning, to ask him to spend more years becomes difficult. Second is that uh, there are brilliant students with MBBS who for some reason did not get MD seat. My personal experience, I strongly believe that there are brilliant candidates who just did not know how to crack the entrance exam, so to say. But and therefore, I have been a strong supporter of the fact that even MBBS person should be allowed. Tell me, Dr. Ankur, that an MBBS person, an MD, a person who's doing his MD, one day before his MD exam, he's MBBS.
Yes, sir.
One day after his exam, he becomes MD. Do you think in 2 days his knowledge really changed anything? So, whatever an MD can do, an MBBS with 2 3 years of training can do equally well. Okay. And it's like saying that men only can do it, women can't. I strongly believe there's nothing the women can do that men can do. So, same way, there's nothing that an MBBS doctor can do. Regarding so initially for many years we had restricted it to just Indian doctors, but for the last 3 4 years, candidates from around neighboring countries, Bangladesh, Sri Lanka, Middle East, lots of candidates have been coming in last year, and in fact this year there have been a doctor from Florida, USA, and we've had one this year registering from Africa, there, who's an African intensivist. And I got a call today from uh, another country which I don't remember, but so called, second world country, there, who said that they didn't have critical care training there. So I think it's not something that we just want Indian intensive care to be good. I want all sick patients to get the best treatment at an affordable rate. And I sincerely believe that if you leave out the developed countries, leave out America, Europe, and Australia, the rest of the world has similar problems. Okay, the, we have got to offer them good quality care, which is not a necessarily expensive care. And I strongly believe that you don't have to do over investigation of patients to come to a diagnosis. Very often you can narrow it down by simple tests, and then if you require, do a more focused investigation and quickly start the treatment, because delays in diagnosis are going to result in a bad outcome.
Thank you, sir. It was so encouraging. So, with due respect to all the postgraduates, those who are listening this, what sir meant to say that though we have a post graduation training, it's good that we can apply because there are many options for them. You can apply for intensive care or critical care training. But at the same time, if somebody wants to pursue their career specifically in critical care medicine, just after graduation of a medical degree, that is also possible. It's and that's the need of the hour with a country so large at this stage, and even in the whether a developed country or developing countries, the demand for intensive care is so large that if someone wants to dedicate their career in intensive care, they should be given an opportunity. So that was the purpose. And I really thankful to you, sir, that you have changed the lives of so many graduates, postgraduates, not only across the India and across abroad. So, one more question. One part of that question remain unanswered, sir. Whether they somebody if applying from globally or somebody apply from India, whether they need to leave their job and come to a certain institute to do this fellowship, or is there is a model by which they can continue their job and then they can pursue this fellowship, whether PCCCM or FCCCM from their working place. Sir, we
Thank you.
lost.
That's I
Hmm.
forgot to answer that. Can you hear me?
Yes, sir.
Yeah. I forgot to answer that. It's a very, very important question. No, you don't have to leave your job. It's not possible for everyone at this stage because that's where your income comes from. But there are some students who want to work under a mentor. They have that option. We have close to about 100 actively training hospitals, though the number of hospitals that are applied for recognition is maybe double or triple that number. Then there are people who are either abroad or are busy into practice, but they work in an intensive care unit. And so a lot of teaching is now online. Weekly, once or twice classes. Then there's a 4-day orientation course, very intense. And then there's a just before the exam, there is a crash course, which is a rapid revision of important things. And so you can attend the orientation of 4 days. You can attend the crash course for a few days. Rest of it is online, so you don't have to really come. Continue working there. You are the college continuously guides you as to what you're doing. The college monitors your performance there, and you get trained actually to be a teacher because in your second year, that is the FCCCM exam, you are involved in a teaching program for the PCCCM candidates. So you take topics, your style of presentation, and everything is critiqued. Improvement suggestions are given, so you become a better presenter, which is a must as you go ahead.
So again, those who have still further queries means, so this has been clarified that you can continue to work where you are working and can apply for the course, not only across the India, from abroad. Also, if you want to get associated with a certain institute, can approach the college and then can look out for the options. For more details, you can again, I am repeating the website. It's collegeofcriticalcare.com. Don't go to any other website which some are fake. We had a candidate that who by listening searched Google FCCCM, FCCCM, landed upon a different website, and then there was some issue fraud sort of thing. So the website is collegeofcriticalcare.com and also icueducation.com. These two are associated with CCF. Now, sir, one more question, that is it possible to totally do this, get this Sherlock Holmes approach online? Because now, because it's a online era, everything is going online. So is it necessary to get enrolled or to associate with institute, or everything can be learned online for this particular Sherlock Holmes approach?
Well, you can learn some aspect of it online, but I don't think you will become Sherlock Holmes by reading a book. It's like, can you fly a plane by reading a book? Okay. I would be very hesitant to sit in a plane where my pilot has never seen a plane, but he's read books and learned how to fly. So you've got to be there. You've got to get the feel of the patient there. You've got to be able to make bedside diagnosis properly, take decisions at the bedside. So that training must be there. Yes, you can learn how electrolytes behave and ABG interpret. There are many things that you can learn online if you stretch it, but nothing like making mistakes in front of a teacher who can guide you, or nothing like you learn from making mistakes. And the biggest handicap to learning is not committing an answer. You imagine 40 people sitting in the audience, people behind saying, when you ask a question, two, three will raise the hand. They're the bold ones who don't mind being, found that they don't know. Majority will sit behind, oh, I didn't understand, I'll read this later on, or why should I commit an answer? And when you tell them the answer, they would have said, yeah, I would have also got the same answer. Maybe I would have taken 10 more minutes. That is the biggest handicap because they're fooling themselves. Go ahead, make mistakes. It'll be fun. People will laugh. I do that. When Ankur was there training under me, these residents used to play a game where they knew the cases at night, and I would come in the morning. They wouldn't tell me the diagnosis, and they would say, "Sir, Sherlock Holmes time. No history, no touching the patient. Guess what it is." Very often I guessed correctly, but sometimes I was wrong. And they would have they would laugh, they would look at each other, and that naughty smile they would give each other. No one can be 100% Sherlock Holmes, and you will make mistakes, but every mistake will teach you. And because you commit, you will learn faster. If you don't commit, then you will never learn. Commit mistakes.
Fantastic. Sir, the audience which is listening right now, on behalf of them, can I make a request to you, if you permit?
Go ahead.
Sir, you said that for this learning these courses, we need to somebody needs to apply for CCF or PCCCM and FCCCM. But you also said that previously you used to take this 4-day workshop for your candidates to get a orientation about this. It's an orientation course which is being taken for the candidates to get a glimpse of this Sherlock Holmes approach, and then they get into the course. So, sir, can you have a 3 or 4 day workshop for our ESBICM and the ICU channel members? Physical workshop. If not, I don't want it online. We can have a later on session, but a physical workshop where they can attend, they can interact with you. You can have this some 40-50% of the idea learning the bedside approaches, and when they can go to their places and have a different mindset and they can teach their students like that. Means, if it is it possible?
Of course, it's possible, and it's very difficult to say no to you, Ankur. That's one thing. Yeah, it's you're such a very nice person. It's never no. We did do this a few years back, and the response was fantastic. We You won't believe it, because at that time we had kept it limited to 30 people. We had a 4-year waiting list, and we did this 3-4 times a year. 4-year waiting list. We did that for 10 years there, and then we stopped because. But I think I am impressed with the students that you have in your ICU channel. There, it's a very large number there, and if enough people are there willing to do it, we could maybe 100, 200, whatever. We could then organize it, and you're a good organizer, and we could do it somewhere.
Thank you, sir. So,
Meeting physically,
uh,
meeting physically and listening is very different. I'll give
amazing.
you an example. One of the teachings we ask a very simple question.
Uh,
Patient comes with gastroenteritis. Okay. Um, how will you write a prescription? Just write a fluid prescription for the first day. I thought there's nothing more straightforward and simple,
uh,
right? And the audience consists of senior doctors. I thought that they would write in 5-10 seconds, they would write a prescription, but they didn't know, hardly anyone was writing. And I asked, why aren't you writing? They said, because you're going to check us, and you will pick up mistakes. And it's nice to be ambiguous in the shadows, write whatever fluids, and sometimes in spite of us the patient gets well, you know uh, so lots of things people don't think about. They give potassium in normal saline, which isn't the best way to give potassium, and you can't give it in glucose. So the little basics, your fundamentals of medicine, fundamentals of critical care need to be good. And it's that little edge, the 2%, 3% edge that you get, which will save your patient's life and make everything much better.
Thank you, sir, and I will surely work out on this. And the audience who are listening right now, to all each and everyone, if you want to get or want to get this physical workshop organized on Sherlock Holmes approach 3 4 day organized, do post in the comment section so that we can know that you all people want this, and then we can organize something in the this year only. We can request ESBICM requesting to CCF. It's like two systems collaborating with each other. We'll try to do this, sir. Thank you for your time. But before ending this session, sir, do you have some words of wisdom, or some? Or it means every word which you say is a word of wisdom, but some message for the audience which is listening. They have immense respect and passion for you, and they love to hear from you.
You call me old fashioned, but I am very, uh, I believe very strongly that India and all developing countries and our patients are our God, and we must do everything to give them the best treatment. And I approach it with a tremendous personal integrity and knowledge, and never hesitate to acknowledge that you don't know something and you look it up. We do that all the time there. And if possible, if you're fortunate enough to learn this approach, your life will change. And this is what I've heard from hundreds of students that have trained, that my life changed. And to me, that's the biggest reward, that the life changed and that they were able to carry forward this good work, this legacy. So that's what I would say. You need to make an effort. Everything cannot happen online there, and you're at least getting an opportunity. Ankur is doing such a Dr. Ankur is doing such a good work in spreading knowledge there, and the world is getting smaller. So my colleagues who are there in different countries, like this young doctor from Africa who rang up, I envy him, because if he's the first trained person in his region or in his city, he will be people will look up to him. He will be like the founder of something new there. It will be like a root that's in the ground, and a plant, the whole tree, a powerful tree is going to grow out from there. And therefore, each one of us has an opportunity, especially if we are far away, to actually make a big impact in the region. How often do we get to make an impact at a city level or a state level or a country level? You're very blessed if you get that opportunity. So work hard, do the best that you can, and you're not alone. Whether it is ICU channel with Dr. Ankur, or it is Critical Care Education Foundation with me and the team that is there, you're not alone. We're always with you. Okay, reach out. Okay, be honest, discuss things, and I'm sure something good will always come out of it.
Thank you, sir. I have technically no words to say thanks to you. Only Charan Sparsh means that's all I can say. And to again those who the audience, the channel members, those who have listened this session this far. Again, I am reminding, if you want to pursue any course, go to collegeofcriticalcare.com or icueducation.com. Also, if you again want that 3 or 4 day workshop with CCF for that Sherlock, how to learn or have a glimpse of Sherlock Holmes approach, do write in the comment section, and we'll try to organize in getting in touch with the sir. So thank you, thanks a lot, sir, and wish you all the good health and all the good wishes from my side, and the all the audience, and your from your students and people those who are listening. Thank you. See you soon.
Thank you very much. Thank you. Have a good day.
Thank you, sir.